It's Friday, the 6th of September, and this is the Hot Topics podcast. Welcome to the Hot Topics podcast from NB Medical. Neal Tucker here as usual, and notionally, this is episode 1 of season 6. We usually start a new season after the summer holidays. Fundamentally, though, things haven't changed. We'll be updating you with the latest and most interesting research relevant to us in primary care. We'll also be having some interviews with interesting people from the world of research and general practice. We'll be talking about the news. We'll be talking about news for NB Medical as well. And maybe when I get time, the songs will return. Today, we've got 3 research papers to think about, one in the BMJ on SGLT2 inhibitors and dementia, one in the Lancet on de-escalation of anti-platelets after acute coronary syndrome, and finally one in JAMA on the effectiveness of the respiratory syncytial virus vaccination in older people. I think that one caught my eye because that's one of the topics which we're not going to be covering in the new Hot Topics course. So in a couple of weeks' time, on Saturday the 21st of September, we have the new Hot Topics course, brand new and updated over the last year. But as usual, we've got too much stuff to fit into a one-day update course, so RSV vaccinations didn't make the cut. We will talk more about them later. Today, let's get straight down to the research. So if you were going to take one medicine to improve your long-term health, what would it be? Aspirin, statin, ACE inhibitor, maybe just give yourself bucket loads of amoxicillin, hoping to stop that future pneumonia. I've got friends who are just back from their summer holiday away. They were visiting family abroad. You hope when you go on holiday that you're going to have a relaxing time, but not for them because their parents both have dementia. They still live at home by themselves. They are physically well, but they are cognitively broken, and they do really need support. And that support comes from my friends when they visit. I suspect lots of you are living very similar lives. Perhaps your parents are much closer and you're doing this on a regular basis, and you'll all appreciate that this can be really hard work. So there's dealing with the now, but there's also thinking about the future. And of course, a family history will confer you with a higher personal risk. So can anything be done? Well, of course, we know that you can live a very clean lifestyle, you can exercise and have a great diet and all of those kind of things. We have been presenting on the last Hot Topics course about the benefits of maintaining your senses and the benefits of hearing aids for people with hearing loss. That makes a substantial difference. And then on the horizon, we've got these fancy new monoclonal antibodies, which unfortunately have shown pretty limited benefit with some serious side effects and all at a really inflated cost. What about then existing drugs? The SGLT2 inhibitors over the last decade seem to have started treating just about everything. Could they treat dementia? So we have a new BMJ paper trying to answer this question. This is a population-based cohort study, and it's probably worth just thinking about the caveats for us in the UK at the start of this, and that's that this is a study from South Korea using their National Health Service data. It's always hard to know how directly comparable a population is. We've got less kimchi, they've got more K-pop, but at the end of the day, we are all still human beings. I think, therefore, this is still very relevant, and presumably the BMJ did too. Why, I hear you ask, would a drug that acts on the kidneys help dementia? Well, partly perhaps through those indirect cardiometabolic benefits that we've seen in a range of different conditions linked with SGLT2 inhibitor use, but also it crosses the blood-brain barrier where it may have neuroprotective effects. Some data has already suggested that that's a feature of this drug. It can act on SGLT2 receptors in the brain. It can inhibit acetylcholinesterase. All of this sounds quite promising. They collected data on 40 to 69-year-olds between the years of 2013 and 2021, with 111,000 patients initiating either an SGLT2 inhibitor or a DPP4 inhibitor, so one of the gliptins, which was essentially the control group during that time. And the primary outcome they were looking for was new dementia. Their data showed that the incidence rate of new dementia was 0.22 per 1,000 person years for those taking an SGLT2 inhibitor, compared to 0.35 per 1,000 person years on DPP4 inhibitors. That gives a hazard ratio of 0.65, basically a third reduction in the rate of dementia if you were using an SGLT2 inhibitor. That actually improved more the longer you were on treatment. So if you were on that for more than 2 years, it was almost like a halving of your risk. You might assume that that's going to be most applicable for vascular dementia, but they found the same kind of benefits or similar benefits for Alzheimer's as well. So that sounds very promising. It is, of course, observational data, and we can only say, therefore, that SGLT2 inhibitors are associated with a reduction in dementia, not that they can cause a reduction in dementia. Beyond the obvious issues of confounding, which they went to great measures to control for, there were some other limitations with the study. So, for example, a fairly short follow-up period for those people that they were looking at. Also, of course, we're looking at a younger population here. It'd be interesting to know what happens when people are into their 70s or their 80s. Is it still worthwhile giving these treatments then? Ultimately, as the authors of the paper point out, what this really needs is to all be confirmed in good randomized controlled trials. It'll be interesting to see how they undertake long enough and large enough trials to actually demonstrate a positive outcome. Still, if you're worried about the possibility of developing dementia and you're trying to get some of these medications, don't worry. Maybe you'll get lucky and get heart failure, CKD, or type 2 diabetes first. Okay, let's move on to our second paper. This is in The Lancet, and it's a reminder to me that I haven't worked in a hospital for 15 years. Even when you're doing a job, trying to help people keep up to date with medicine in general practice, it's still easy to get behind in lots of other fields. Back in the day, if you had a heart attack, they'd stick you on aspirin for life, and that was the end of it. Now we don't even call it a heart attack. You have acute coronary syndrome, and that could be an NSTEMI, a STEMI, it could be unstable angina, it could be some things that I haven't even ever heard of before. And there's a whole menu of anti-platelets these days, not just which ones you're going to have, but which combinations you might have and how long you're going to take them for. The background to this paper then is that these days it's most likely after acute coronary syndrome that you're going to get dual anti-platelet therapy. Classically, you're going to get that for 12 months and then revert to monotherapy, which is typically aspirin for life. If you give dual antiplatelet therapy after acute coronary syndrome, you reduce the recurrence of ischemic events. The thing is, even though we typically give dual antiplatelet therapy for 12 months in this situation, it's thought that most of the benefit is in the immediate period, the first few days or weeks after an event. And that's mirrored in what we've seen with TIAs, for example, where we give 21 days of dual antiplatelet therapy and then we de-escalate that back down to monotherapy. This Lancet paper then is trying to answer the question, can we do the same after acute coronary syndrome? Because the less time you're on dual antiplatelet therapy, the lower your bleeding risk is going to be. This then is not a randomized controlled trial. This is a systematic review and meta-analysis, as there's already a few trials which have explored this. In fact, they found 6 which met the inclusion criteria. This equates to 23,000 patients worth of data. Those studies compared de-escalation regimes, bit of heterogeneity between them. Some of them were as short as 2 weeks, some of them up to 3 months, with the median number of days to de-escalation being 78. And they compared that to standard 12 months of dual antiplatelet therapy. And their primary outcome measures were rates of MACE, so that's that composite endpoint of cardiac death and non-fatal MI or stroke, and the rate of serious bleeds. The data showed that de-escalation strategies were non-inferior to standard one-year dual antiplatelet strategies. So there was no increase in ischemic events or death, but there was a reduction in bleeding rate as measured on the BARC scale, specifically BARC scores 3 and 5. Now, I'd not come across this bleeding rating scale before, so I presumed initially it was determined by how mental your dog was going whilst you lie on the floor in a puddle of your own blood. Turns out this is not a linear scale, but these are discrete categories. BARC 3 indicates overt bleeding with a drop in hemoglobin of at least 3 points, and BARC 5 is probably fatal or definite fatal bleeding. How bleeding can be probably fatal, I'm not entirely clear. I would hope that most clinicians can distinguish between someone who's dead and someone who's not dead. Anyway, good news, I suppose, if earlier de-escalation is adopted, then we'll have to worry less about the BARC scale. Interestingly, they also demonstrated a mortality benefit with a 0.3% absolute risk reduction using that de-escalation strategy. But before we get too excited, it was barely statistically significant. I mean, I suppose you would say that that is statistically significant, but when you look at the confidence intervals, it doesn't inspire that much confidence in this finding. Ultimately, decisions around dual antiplatelet strategies after MI are going to be the purview of cardiology, but it does sound like this research may start influencing those decisions. Learning points for me, well, sometimes less is more. Indeed, it seems in general practice that often less is more. And also, as the editorial points out, perhaps aspirin's days are numbered. For years, we've thought of that as the go-to monotherapy for the rest of your life. Well, actually, it may be that that's going to be replaced by ticagrelor in the not too distant future. Finally, we've got our paper in JAMA on respiratory syncytial virus vaccination in older people. And this caught my eye because a couple of months ago, I was updating the Hot Topics book and I was writing about RSV vaccinations. It's a hot topic at the moment because it's just being introduced into the UK vaccination schedule for 75 to 80-year-olds. Why vaccinate this older group when we know that RSV is a disease that causes bronchiolitis in kids? Well, it also causes problem in older people too. So it's linked with increased mortality, hospitalizations, viral pneumonia, exacerbation of underlying conditions like COPD, cardiovascular events, and so forth. It's apparently associated with 175,000 GP episodes in this older population per year in the UK and 7,500 deaths. If there was a good vaccine, then we can save a few lives and perhaps all go home a little bit earlier each day too. The existing data is promising. So, published in the New England Journal of Medicine last year, it demonstrates good vaccine efficiency against severe lower respiratory tract infection. But what, as the JAMA paper's authors point out, those trials did not show, because apparently they were underpowered to do so, was to look at whether the rates of hospitalisation improved with vaccination. To answer this question, the authors performed a case-controlled study in the US. They recruited 3,000 patients with acute respiratory infections in outpatient visits. That's probably as close as you can get to essentially going to the GP here, but in the US. And of that 3,000, 367 of them had proven respiratory syncytial virus, whilst the rest were considered control groups. They then compared the rate of hospitalizations between the two groups to get the vaccine efficacy against RSV-associated hospitalization, and it came out as 75%. So that vaccine will prevent 75% of RSV-associated hospitalizations. Of course, they started at 60 years old and we're vaccinated from 75 years old. Helpfully for us, the authors looked at these two specific groups and found, regardless of age, you had the same vaccine efficacy. Previous data has suggested that this is a very safe vaccine. So the conclusions I guess we can take away from this new research is that as we embark on this new vaccination program, we can be very positive with patients about the benefits of this treatment. Given that it's going to be increasingly difficult for anything to kill older people, if I were them, I'd probably get myself the jab and then try and bag myself some SGLT2 inhibitor at the same time. Better safe than sorry. Okay, that'll do for the research today. Thanks for listening to the podcast. As always, we'll be back in 4 weeks' time. By then, I hope you will have joined us for the new Hot Topics course. Don't forget, that's Saturday, the 21st of September. It'll be available on demand if you can't join us live. And of course, we've got loads of other courses that are going on at the moment over the next few weeks as well. So don't forget to check out the nbmedical.com website. Don't forget to sign up to NB Plus, all of our online courses and much more for just over £300 a year. And in case that's not enough for you, remember to enjoy yourself as well. Take care. Bye-bye.